Hi, everybody. Welcome to the third webinar in our 2025 webinar series, which is titled Mastering Lewy Body Dementia Together. That's for the whole series. My name is Keith Fargo, and I'm Director of Scientific Initiatives here at the Lewy Body Dementia Association. This year, Rose, do we have the slides up? There we go. Thank you. This year, we will be exploring a range of topics to help you better understand Lewy body dementia and its symptoms, strengthen your ability to advocate for services and support, and pick up new tools and techniques to live optimally. Rose, next slide, please. Thank you. LBDA's mission is to optimize the quality of life for those affected by Lewy body dementia. And to do this, we accelerate research, accelerate awareness, advance research for early diagnosis and improved care, and provide comprehensive education and compassionate support. Next slide, please, Rose. Let's start with a few technical details before I bring in our presenter today. So first up, to launch closed captioning, you can select Show Captions at the bottom of your Zoom toolbar at any time throughout the presentation today. Also, I want to draw your attention to the resources icon that's at the bottom of the same Zoom toolbar. That resources icon has links as well as downloadable resources that accompany today's session. If you would like, you can print out the webinar worksheet included in the resources to guide you through how to apply today's information. You are encouraged to please submit your questions through throughout the presentation using the Q&A icon. And following the presentation, we're going to address as many of those questions as we can with today's presenter, Dr. Galvin, from that audience Q&A pool. So remember, type those into the Q&A using that icon at the bottom of your Zoom toolbar. My colleague Rose, who we've already heard from, is going to be dropping links into the chat throughout the presentation. And these links will also be in your email inbox in about 1 week from today as part of our post-webinar thank you email. This presentation is being recorded, and an email will be sent to those who registered with the link to view the recording in about 1 week's time. When you leave the session today, a brief survey will appear asking you for your feedback about today's presentation. We truly appreciate it if you take the time to complete that survey because that helps us inform our content for the remainder of this year as well as future years. Rose, slide 4, please. Thank you. You can keep learning until our next webinar with our on-demand learning options. Recordings of all of our past webinars can be found on our YouTube channel, LBDA TV. And then Rose, next slide, please. We also offer the Lewy Learning Center, which has courses on a variety of topics that you can watch, rewatch, and share with your friends and family. Rose, slide 6, please. Thank you very much. You can also watch the short film Spark about Robin Williams' battle with Lewy body dementia and other video offerings on our Mediflix channel. And next slide, please. We'd also like to invite you to join our social media channels to hear about upcoming LBDA webinars and other programs. Rose, next slide, please. And of course, you can always visit us at our home on the web, lbda.org, for all of your other LBDA needs. That's the end of the intro slide deck. Now I'm going to ask you a little bit about who's joining us today, who's with us in the audience, and what your experience has been with Lewy body dementia. And this really helps us to make sure that we are, aiming these webinars at the right level. So Rose is going to launch that poll now, and you should be able to answer that on your screen. All right, it looks like we're getting some responses in here. We'll leave this up for maybe 20, 30 seconds. So the question is, how long have you been either living with LBD, treating, learning, advocating for Lewy, or other? All right, it looks like we have a lot of people here who are relatively new. So the Vast majority of answers are coming in at 0 to 3 years. That's about 70%. We've got about a quarter of you are at 4 to 8 years. And then a smaller number, approximately 6%, have been at with Lewy 9 years or more. So we're going to stop sharing those results. All right, now we've got another poll here. This one is actually on today's webinar topic. And so the question for you is, how knowledgeable are you with today's webinar topic? And again, we'll leave this up for about 20 or 30 seconds. All right, we're seeing a really nice balance here. Excellent. I'm going to end the poll and share these results. So it looks like we've got about 40% of you say that this is a brand new topic for you for today's webinar. About half of you are saying, I know a little bit about this webinar topic. And about 10% are saying very knowledgeable about today's webinar topic. So even those of you who are very knowledgeable about today's topic, I think you're still going to learn something from Dr. Galvin today. So thank you for joining us today. And speaking of Dr. Galvin, let's go ahead and bring him in now. So Dr. James Galvin is the, James Galvin, MD, Ph.D., or sorry, MD, MPH. Jim, I promise I'll be able to read by the time we get to the end of the webinar today. Dr. Galvin is professor of neurology and psychiatry and behavioral sciences and the Alexandria, bear with me for one moment, and the Alexandria and Bernard Schoeninger Endowed Chair for Memory Disorders at the University of Miami Miller School of Medicine. He is Division Chief for Cognitive Neurology, founding director of the Comprehensive Center for Brain Health, director and principal investigator of the Lewy Body Dementia Research Center of Excellence, and the principal investigator for the Native Alzheimer's Disease Resource Center in Minority Aging Research. Dr. Galvin has authored over 400 scientific publications and is principal investigator on 12 active NIH grants, having received over $120 million in research funding from the National Institutes of Health and private foundations. Please use your reactions tab to help us give a warm welcome to Dr. Galvin. And Dr. Galvin, take it away.
All right, thank you, Keith. Oh, I got lots of little hearts and thumbs up. That's great. Let's see. Try to share my screen. Hopefully that'll all come up nice. All right, hopefully you all can see my screen. So what we're going to do is going to go through a little bit of a whirlwind of information, talking about the results of clinical trials and get a sense of where we are and where we're going. So many of you know this, but I think it's good as a background just to think about this. When we talk about DLB, it's really a complex multi-system disease. So not only are there cognitive symptoms, but there are also psychiatric and behavioral symptoms, there are motor symptoms, there are sleep symptoms, and what we call autonomic features. And if you think about sort of the cognition, there's changes in memory and other thinking abilities, but we also deal with this concept of the cognitive fluctuations. The psychiatric symptoms include things like hallucinations, delusions, depression, anxiety. The motor symptoms, of course, are the Parkinsonian features. The autonomic systems are really things that bother people that often aren't thought about as part of the disease, but they are, but things like constipation, orthostasis, that's dizziness when you stand up, urinary symptoms, trouble digesting food, difficulty swallowing, drooling, and of course the sleep symptoms are a whole host of symptoms, but include things like REM sleep behavior disorder. So it's really a complex disease. Now, because it's a complex disease, that leads to a bunch of complex problems how to think about it. So when we think about it, it's very heterogeneous. There's a range of symptoms and they're expressed differently between different patients. That range of symptoms also has a range of severity. So while some symptoms are bad, some symptoms are very mild, and that may change multiple times over the course of a person's life. The symptom severity may fluctuate within and between different patients. And here's the real kicker, and I'm going to bring this point back up several times during the rest of the talk, is historically treatment of one symptom. So you improve one symptom often leads to the worsening of another. And this makes it a very, very difficult disease to treat. And so when we think about some of the newer medications, we can start to think about, well, how are they affecting multiple symptoms, not just cognition? Now, right now I'm showing you all of the approved medications for dementia with Lewy bodies. You'll notice it's a blank screen because there are no approved treatments. For Parkinson's disease dementia, which I'm not really going to talk about today, there are two treatments that have approval. One is rivastigmine for treatment of the cognitive symptoms, and the other is pimavanserin for treatment of psychosis. So when you think about Lewy body dementias in total, that's both dementia with Lewy bodies and Parkinson's disease dementia, there really aren't a lot of currently approved options. So everything we basically do as a clinician is what we call off-label. We use medicines from other diseases to try to help treat the symptoms that the Lewy body patient may be experiencing. And so they can be helpful. So for example, this little graph right here kind of says what's been happening in terms of trials, looking at the cholinesterase inhibitors like donepezil, galantamine, and rivastigmine for the treatment of Parkinson's disease dementia. And you can see overwhelmingly, most of the studies show a very positive effect. So this has given us evidence that we're able to use these in an off-label use. But what about new medications? So this is currently the clinical trial activity that we can find. So there's a website, it's called clinicaltrials.gov. And so I did a search very recently just to update this slide. There are 207 registered studies. 134 were about some type of intervention and lots of different types of interventions. And 73 were observational. And they went through the full range of studies. So phase 1 are those very, very early sort of first in human studies. And many of those don't move forward. They don't demonstrate what they want, or they're unsafe, or other types of problems. About 32 are in phase 2 studies, and about 10 went into phase 3 studies. And these are the ones that are kind of give us the signal of whether the medication works. And phase 4 studies are trying to do post-marketing surveys. About 40 interventions are active, and then there's lots of different observational and patient registry studies. So 207, that sounds like a lot maybe, but think about it in terms of some other diseases. In Alzheimer's disease right now, today, there are 912 active studies. In Parkinson's disease, 957 active studies. How about other neurological disease? In multiple sclerosis, there's 762 active studies. And even in very rare diseases like ALS, amyotrophic lateral sclerosis, there are 240 active studies. So we're clearly missing the opportunity to really make an impact on our patients. So let's look at some of the things that are in pipelines. So what's really nice is in the literature today, we're able to go ahead and look at what's coming down the road. So here's the pipeline for Alzheimer's disease. Pretty busy, right? And so all these different dots represent different drugs and different levels of development, from the outer rim, the phase 1, all the way to the inner rim, the phase 3, the ones that are trying to get registered for approval. And there's multiple different classes of medications and multiple different types of volunteers participating in the study. So very active pipeline. Here's the Parkinson's pipeline. And again, the graph's a little bit different, but it's in principle the same thing. Lots and lots of different possibilities. It's very, very exciting. So you say, well, okay, here's the pipelines for these two diseases that are very similar in some ways to what happens in DLB, but yet different. What's going on in DLB? Well, here's the pipeline for DLB. And I think you can appreciate there's a lot fewer targets, right? We don't have much in the way out in phase 1 in these categories. We only have one medication in phase 3, and that's an old Alzheimer medicine, memantine, or when it was branded, it was called Namenda. So we really need to have greater research, and hopefully we'll be able to move some of these phase 2 drugs into the phase 3 level. Another really exciting thing is trying to repurpose drugs. Now that means that the drug already approved for some other use. Now the advantage of that is that we already know a lot about the safety of the drug. And so you really just need to try to demonstrate efficacy, effectiveness. And so here was a paper that was published by a group, and I was fortunate enough to participate in the study group, and trying to look at the literature, identify some drugs that looked promising. And the most promising one was a drug called Embroxol, which is not available in the United States, but it's being tested in Europe. So let's now look at sort of the total history of more recent trials in DLB. And so, here are the last 15 or 20 so trials, and some of them have been in DLB, some of them have been PDD, and some of them have been in both DLB and PDD. And I think you can see, for the most part, they've been negative studies, and that's been very disappointing. The one thing I want to let you know is that even in a negative study, we actually learn a lot. So we can use those lessons learned from a negative study to help us design the next study. What I'm going to do is focus on these 3 completed studies and give you a sense of what's happened. So the first study I want to talk about is the nolotidib study, okay? And this was done by a group in Georgetown University in Washington, D.C. So it's a single site study. Sharbo Musa is the principal investigator of this, and he's the director of the program. Now, nolotidib is an anti-cancer drug. It's used for leukemia. But there's animal data that suggested that low doses of this drug could potentially reduce inflammation and improved behavior. So that would suggest then we could try it in clinical trials. So in an earlier study in medically optimized, moderately severe Parkinson's disease patients with mild cognitive impairment, showed that nolotidib did not improve motor function. But longer-term treatment seemed to preserve motor function, rather, so there wasn't decline, but also there didn't seem to be any cognitive decline compared to a much lower dose. So that would suggest that maybe this could be used in a clinical trial. Now, nolotidib poorly penetrates the brain, so it doesn't reach the concentrations to reach the target enzyme, which is responsible for its cancer chemotherapeutic approach, but it does reach enough of a concentration to target another enzyme or receptor. So this is what we think is happening. So let's talk about this study. So this study was completed. It enrolled 164 people were assessed. Then 43 were randomized. There were a lot of people who either screen failed or didn't meet inclusion. So those 43 were randomized into 2 arms. One got a placebo, and one got 200 milligrams of nolotidib. And so they went through, and at the end analysis, there were about 18 to 22 people in the 18 of 22 people in the placebo arm and 19 of 22 people in the treatment arm. Okay, so this is what we're going to look at for some of the results. Let's look at some of the sort of demographics first. You can see that the total enrolled again was 43. 36 finished the total study. Some dropped out. The average age was in the low 70s, about 73. Mostly males, not surprising since DLB tends to be more prominent in males. Mostly white. And their scores in the Montreal Cognitive Assessment would suggest a mild to moderate stage, and their Parkinson rating scale showed some mild Parkinson features. There weren't a lot of serious adverse events, so overall there was a pretty safe signal. One of the things that did happen, though, is we noticed that nolotidib seemed to reduce falls by 70% in patients with DLB. So there were much fewer falls in the treated group compared to the placebo group. If we look at some of the background evidence, the nolotidib at that 200 milligram dose seemed to increase the levels of dopamine in the brain and had a trend toward reducing the amount of synuclein in the brain. Synuclein is the protein that builds the Lewy body. So it seemed to increase dopamine, which helps with movement, and seems to decrease synuclein, which is the pathological cause of the disease. It also seemed to affect Alzheimer-related biomarkers, including tau and amyloid. Again, these were modestly significant, so showed us a signal, and that's important because we can see some biologic effects. When we look at some of the clinical data, what we saw is that there was an improvement in cognition, but not in motor. So this slide over here, the ADAS-Cog scale is a cognitive scale that's used in clinical trials, and we compare the placebo group to the treated group, and in this case, going down is an improvement in scores, and you can see that there's a significant difference between the two groups. There was, however, no difference in their motor, and that was consistent with the prior studies. There didn't seem to be any improvement on the motor side. We looked at some other outcomes. There was some improvement in the behavioral symptoms and in the number of fluctuations. So there were fewer fluctuations. So this suggests that we were able to affect cognition, affect some behavior, and the fluctuations didn't do much for motor. So that's a promising small study, and the plan is to go ahead and try to do a phase 3 study. The group has written an NIH grant, and I guess we'll just have to wait and see what happens with that. That phase 3 study would be a multi-site study. Let's move on now to the next study, which is the SHIMMER study. This used a compound called what was called CT1812. It now has a name, zerbimazine. This is a collaboration with Cognition Therapeutics, and this was funded by an NIH grant as addition to some other monies. And this was a first-in-class molecule. And what it tries to do, it tries to block the binding of pathologic proteins on the cell. So it binds to the sigma-2 receptor and displaces these abnormal protein aggregates from the cell. So it has some protective benefits as well as some modification benefits. So this was done in a phase 2A. So this is the early part of the phase 2, multi-site study in 120 individuals. That was the plan. So you can see that this was the study design. We enrolled people aged 50 to 85. They had to have an MRI before the study started. They had to have a DLB diagnosis, and they had to have a mini mental state score between 18 and 27. So mostly mild with some moderate people as well. The treatment period was for 6 months. Now we targeted 120, but we were actually able to enroll 130 individuals across 31 sites, including a number of the Lewy Body Dementia Association Research Centers of Excellence. There were 3 arms. So this is a 1-to-1-to-1 randomization. So those 3 equal arms. One got a 300 milligram dose, one got a 100 milligram dose of CT1812, and then there was a placebo arm. And then we did a bunch of assessments looking at safety, because that's the primary feature of the phase 2A study. And then lots of outcomes looking at efficacy signal, including behavior, cognition, fluctuations, motor, sleep, global impressions, and biomarkers. So this is the baseline characteristics. There are 3 groups. They're pretty equally enrolled. They're nicely balanced. So there's no differences in age. There's no differences in the amount of men. There's no differences in race. They were balanced in terms of their cognitive baseline and their other features. About 80% or so had a positive skin biopsy. So we're able to demonstrate biologically that they had Lewy body dementia. About a third of them had concurrent Alzheimer's disease. About 80% of them were treated with some standard of care medicines, and about a third of them were getting Parkinson medicines, some type of a dopaminergic agent. So again, we screened 293, we randomized 130 across the 3 arms. Most people completed, which is great, which allows us to do our pre-specified analysis. So I'm going to show you the data for this study. And the way I'm going to show it to you on a number of the slides is I'm going to show you data for each of the 3 arms, and then I'm going to show you the pooled data, which means I'm going to combine the 100 and 300 milligram arm into a single line so you can compare treated versus the placebo group, okay? So that's going to be the basic pattern. So let's start with the first outcome, which is the neuropsychiatric inventory. So this is capturing behavior, including hallucinations, anxiety, and delusions. And these are some of the most prominent symptoms that are the most disturbing to both the patient and to the family. All right, so here's how we're going to look at these next few slides. So generally going down is worsening on these scores. The gray line is the placebo. The reddish or purplish lines are the treatment groups, either the 100 milligram or the 300 milligram. And so you can see at the end of the study, both treatment arms showed numerical superiority to the placebo arm. Now, this is a phase 2A study, so it's not specifically powered to demonstrate statistical differences, but you want to look for two things. One, does it look numerically superior? And two, do the statistics that we can do tend to favor treatment? So remember, the first set of slides I'm showing you are each arm separately, and then I'm going to switch to the pooled arm, which is going to be in blue. And so if you look at both groups together, because now we increase the power to see an effect, we see an 86% slowing in behavioral symptoms. Okay, and if you look at all the different 12 domains on this, overall, the NPI favors treatment with CT1812, particularly those three important areas: hallucinations, anxiety, and delusions. Now, when we measure behaviors, we can also measure distress. So how much does that behavior distress the caregiver? So this is a sort of a sub-analysis of the NPI looking at distress. And again, you see both arms are superior to the placebo arm. And this just barely approaches significance. So it's very close to being significant. And the other thing I want you to notice is that while the stress increased in the people who were in the placebo arm, in the people in the treated arm, there was actually no change in caregiver distress from baseline. So over the 26 weeks, it did not worsen. If I show you the pooled data, again, you can see that this effect showed 114% slowing in caregiver distress in the treatment arm compared to the placebo arm. And this actually does reach statistical significance. Amongst the different domains, the greatest benefit, again, was in anxiety, delusions, and hallucinations. I'm going to show you some memory testing now. So this is a computerized memory test. It has a bunch of different subtests, and we can see slowing across multiple of domains. So we saw slowing in second episodic memory, in quality of memory, and in working memory. And these are some of the individual tests within those composite scores. And so you can see overall the performance tends to favor treatment with CT1812. This was improved memory accuracy for word recall, picture recognition, and working memory. That's manipulating information. So if I show you these lines now, again, you can see that for episodic memory, both arms were numerically superior to the placebo arm. We saw sort of a messy signal with working memory and quality of memory, with a better performance in the 100 milligram group compared to the 300 milligram group. If I show you the pooled data, what we see is somewhere between a 59 and 85% slowing of memory decline with the treatment group compared to the placebo group. What about cognitive fluctuations? So these are spontaneous changes in alertness, attention, responsiveness, and they sort of come and go. And we use a scale called a clinician's assessment of fluctuations. And what we saw, again, at the end of the study, the treated arms were numerically superior to the placebo arm. And if we look at the pooled data, there was a 91% slowing in the fluctuations. Again, if you look across the entire trial, you can see that there's an increase in fluctuations in the placebo arm, but at the end of the study, the treated arm is about at the same amount of fluctuations they were at baseline. So it seems to be a sort of a stabilization. That really leads to probably the reduction in the improvements that we see. What about activities of daily living? Well, we use a scale that allows us to measure that. This is everyday functioning. Things like bathing, toileting, talking, shopping, writing, eating. So we look at both arms. Again, at the end of the study, they're numerically superior to the placebo arm, and they start to approach significance. And if we look at the pooled data, what we see overall is a 52% preservation or slowing in the loss of activities of daily living in the treated arm compared to the placebo arm. So even though there's decline in both groups, there's much less decline in the treated arm. And again, this is right at the margin of being statistically significant. What about motor function? We look at the score, a scale called the MDS-UPDRS. This is looking at the Parkinsonian features. It looks at balance, gait, speech, stiffness, movements, tremor. And we see at the end of the study, the treated arms are numerically superior to the placebo arm. And if I show you the pooled data, there's, again, about a 62% slowing in the motor function in the treated arm compared to the placebo arm. Okay, so now this is really interesting, is because remember I showed you early on is often treating one symptom worsens another symptom. What I showed you so far is that treating the cognition didn't affect and may have actually benefited behavior, activities of daily living, fluctuations, motor function. Now, not every test was positive. We looked at some scales. We had minimal changes on the MoCA, which is a brief screening test. We didn't see any real changes in daytime sleepiness. And again, with the pool data, you can see that, again, we don't see much of a signal here. So if we look at all of the outcomes together, what we can see is across it, there's clear evidence that treatment really favors, or treatment with CT1812 is really favorable across all these different outcomes. We have behavior, we have fluctuations, we have memory, motor, activities of daily living, and global rating scales. Really does benefit. What about the biomarkers? Well, to date, we've not seen any significant treatment differences. We're not finished totally looking at all the biomarkers, but the ones we've looked at so far, we haven't seen a lot of difference. So this is an effect that we haven't been able to quite measure the biomarker changes, other than maybe a small reduction in a biomarker called NFL, neurofilament light chain. This is looking at a measure of neuronal injury and degeneration. What about safety? When we look at all the safety features, they were about the same across all the groups. There were a little bit more side effects in the 300 milligram arm compared to the 100 milligram arm. If we look at the most common treatment effects, really falls being the big one in the 300 milligram arm, a lot less in the 100 milligram arm. So it just gets a sense that the nature and severity is similar to what we've seen in other CT1812 trials, in Alzheimer's disease, for example. So I'll lend this all together. It really gives a favorable safety profile versus placebo. The adverse events were kind of well balanced between the arms. Most of the adverse events were mild or moderate. There were very few serious ones. There were no deaths related to study drug. There was some changes in laboratory functions. Most of the biggest changes were seen in the 300 milligram group, which tends to favor the 100 milligram dose being one that might be carried forward going on to later studies. So that was SHIMMER. Let's go to the next study, and I'm going to try to summarize all these at the end. So this is Rewind LB. This is with neflamapimod. This was a collaboration with what was then known as EIP Pharma, is now known as Servomed. This was also funded by an NIH grant. This is a first-in-class small molecule. It's an inhibitor of a protein kinase. The idea is it may protect the cells in the brain that make acetylcholine. Acetylcholine is really important for both cognitive and motor function. And so this phase 2B study was based on the learnings from the phase 2A study, which was called Ascend LB. This was a multi-site study in 160 individuals. The way neflamapimod works is that it sort of blocks this enzyme and preserves or rescues the basal forebrain neurons that make acetylcholine. And so this may improve, again, motor and cognitive functioning. Really brief, I'm not going to talk a lot about the phase 2A, other than to say it showed an efficacy signal, but more importantly, it told us that the signal that we could see was really dependent on the amount of plasma p-tau 181. So this is looking at neurofibrillary tangles. Now, neurofibrillary tangles are not the predominant feature of Lewy body disease. It also gives us a sense of how much amyloid there might be in the brain. In other words, the people with more pathology had a much less robust response. So this suggested that for future studies, you might want to set up a screening component to look at their p-tau levels. And we really want people with lower p-tau levels. They're the people who are going to be more likely to show a response. And in fact, that was done in the Rewind LB. This is the study design. There was screening and randomization. There was a main study, which I'm going to talk mostly about. And then there was an open label extension, which I'm going to highlight because that data has just been released as a part of a press release. Again, it's DLB by consensus criteria at the mild stages, and they had to have low p-tau 181 that have less evidence of neurodegeneration. We actually randomized 159 individuals. They completed the 16-week main study and then were enrolled in a 32-week open label extension study. So here's the consort flow chart. So we looked at 335 people, 159 made it through that initial screening and were randomized, 80 to placebo, 79 to neflamapimod. And most people finished the study. So that's great because it allows us to look at both our efficacy signal and our safety signals. Looking at the baseline characteristics, well balanced between the two groups. About 71 was the mean age, mostly males. Many mental state scores put people in the mild stages. Their performance and other cognitive and rating scales were also in the mild stages. You can see that most people had cognitive fluctuations, about half had visual hallucinations, about 75% had REM sleep behavior disorder, about 85% had some form of Parkinson features. Most people were on some type of therapy, either a cholinesterase inhibitor alone or in combination. Only about a quarter of people were on no medications as a background. Okay, let's look at the endpoints. First, I'm going to focus on the primary endpoint. So in the green line is neflamapimod, in the placebo was in the dark blue line, and you can see the lines are kind of tracking along. So what we did not see was any signal of a benefit. Really saw no change. It was not anywhere near being significant, and it wasn't numerically different. We're very disappointed about this. If we look at the other outcomes, we see the same exact thing. So in the secondary and exploratory outcomes, really see no signal showing a benefit and really very little separation between the treatment and the placebo group. On the CIGIC, which is a global rating, this is an interview with the patient and with the caregiver by an experienced clinician, really see no signal suggesting a benefit. So it's a negative study based on this. We did look at safety and we didn't see, it was generally well tolerated. There were no new safety signals that weren't expected based on what we knew from phase 1 and phase 2 studies. The most serious adverse events were behavioral disturbance, a pneumonia, some dehydration, some generalized weakness. The most common treatment effects were related around falls. And you could see the placebo and the neflamapimod group had about equal amount of falls. The other ones were less common. So again, disappointing because it appeared to be a negative study. However, when we started looking at other things to try to understand this. Actually, what we found was that the trough levels, that is the low level of the blood with drug, was similar in an earlier study with an ineffective dose. So basically, there wasn't enough medication delivered in order to see a benefit. We looked at the capsules really closely. The capsules looked fine, but it appears that the capsules that were 3 or 4 years old really had very different kinetics. The way they dissolved in the body were very, very different than what was expected. So we think that the reason that was no effect seen is because people didn't get sufficient doses. So essentially, the capsules and the placebo were about the same. So for the new open label extension, there was a new batch of capsules that were introduced. This showed that there was an expected performance in a bunch of healthy volunteers. And so this led to a design change, right? And so we had the placebo group and we had the extension phase. And the extension phase, the 16 weeks have been completed, and there was a press release, which I'm going to go over now. I'm not going to show any of the data from the press release because it's still in a press release form. This data will be presented in 2 weeks in Vienna at the Alzheimer's disease Parkinson's meeting, the ADPD meeting. But I just want to go over the difference between the new and the old capsules. So the old capsules were used in the main study, but some people in the open label extension got the old capsules and some people got the new capsules. This is interesting because it allows us potentially to look at another study. And that study is because about half of the people in the open label extension were getting the old capsules and about half were getting the new capsules, which means that there are 2 arms, essentially, within the open label extension. Everybody's getting drug, but one group is getting a drug that acted a lot like placebo, and one's getting a drug that should act like drug based on what we know. And so at the end of this first 16 weeks, we did find something. So let me talk about that. For the primary outcome, what we found was that there was significantly slower decline in the primary outcome, the CDR sum of boxes, in the new capsule group compared to the old capsule group. And this was highly significant. When analyzed from baseline for of the overall study, that's the initial phase through the open label extension, the new capsules also demonstrated a significantly positive benefit compared to placebo. And the difference was even more pronounced in people who had very low p-tau 181 levels. Now, we did look at the secondary outcomes as well. We saw in the CGIC, which is a global scale, the new capsule showed significantly less worsening. The new capsule showed significantly less worsening than the old capsules. This was also enhanced in people who had low p-tau 181. In addition, we looked at some other things that timed up a go and some other neuropsychological test batteries, did not see differences in this group. Safety data, the new capsules and the old capsules were similar in terms of tolerability, and there were no new safety signals. But what was interesting was that similar to what was seen in the phase 2A study, the new capsules significantly reduced the fall rate compared to the old capsules. Okay, so very, very exciting. In the last minute, I just want to say there are other things coming down the road. I just want to give you another example. This is a grant that I'm one of the PIs on, and this will be a prevention vaccine. So the idea is to try to prevent disease with a vaccine. It's a novel designed vaccine. It has 3 components of the alpha-synuclein molecule, and hopefully in the next 2 years or so, we'll be starting a phase 1A first-in-human study. We've done lots of work with animals and with cells, and we can see that it appears to work well in the animal models. So we're getting ready to think about a human study. Our overall timeline, we're still in the very early phases of the study. So To summarize, clinical trials are in LBD are a top priority. They're a top priority to researchers, to Lewy Body Dementia Association, and to NIH. New diagnostics that are being developed are really helping us identify cases much easier. Randomized clinical control trials in DLB really lag behind the other dementias. And the past studies have mostly focused on symptomatic approaches. There's an interest in repurposed drugs, but the newest studies really offer potential for disease modification. And they're addressing the full range of LBD symptoms: cognition, motor, behavior, fluctuations, activities of daily living. What I shared with you are data from nilotinib, zervimesine, and neflamapimod, and these data truly support moving forward to phase 3 studies. The next steps may be prevention trials, and most importantly, LBDA has been a crucial partner in all of these efforts. I want to thank you for attention, and I think I left enough time for questions.
All right, thank you very much, Dr. Galvin, for that. Very engaging. So attendees, oh, it looks like people already are, but attendees, please take a moment to use your reactions to show Dr. Galvin some appreciation for joining us today and for the presentation. We are going to take some questions now from that we received from the audience. And bear with me while I get the questions pulled back up. They seem to have disappeared when I entered the webinar, but I can get them back. All right, here we are. So we have some technical questions and some questions that are going to be best for you, and some that I might take actually. So here's a question. This is more of a technical question about how trials work and participants who volunteer for trials. Of course, they're all very interested in knowing, people who were in the trial are very interested in knowing if they were on the study drug or if they were taking placebo. Can you give us some general information about when people can expect to find out whether they were on the study drug or on placebo, and who they might find that out from?
Right. So depends a little bit on the study design. And so if there's an open label extension, obviously no one finds out anything until the complete study is done. In studies without an open label extension, typically the data is locked, it's analyzed, it's reviewed. It's reviewed by not just the press release and the kind of presentations like this, but it goes through a detailed review of the study group and the data safety monitoring board. And then eventually what happens, the sponsor will let the individual sites know. They'll be unblinded, and the sites can let the participants know. So there is a lag between the end of the study and notification of the participants of what group they were in. So for example, the Shimmer study has not finished all of those steps that I mentioned in order to do any disclosure. The Rewind LB study is still in its extension phase, right? So the 32-week extension isn't completed yet. So it will take a while, again, to do all of that post-study necessary required meetings before anything is divulged.
Fantastic, thank you. And then when the study sponsors are ready to divulge that, the participants can receive that information from their local sites. Is that correct?
Yeah, so the treatment assignments are coming out from Shimmer. And so hopefully the investigators will have them, they'll review them, and they'll be reaching out to the participants. And again, the other studies will depend exactly where they are in the process of completing the necessary steps before releasing the information.
Thank you. So here's another question. This is technical, and it's what is p-tau 181?
Yeah, so good. So sorry, in a seminar, I'm really trying to go through the data. I didn't go through some of the granular details as much as I normally would have. So tau is a protein that it builds the skeleton of a cell. And so when it's phosphorylated, that is p-tau, it has a tendency to twist and clump. And those clumps are called tangles if they're inside the cell. But it also sticks in the amyloid plaque and makes the little neurites that are in the plaques. So p-tau 181 is a measure of this abnormal phosphorylated tau pathology. It mostly is telling us about plaques, but it tells us a little bit about tangles as well. And the higher the p-tau, the more degenerative processes are present in the brain. So for the neflamapimod study, the idea was we wanted to select people who had low levels of p-tau because those people seem to be more responsive. And that's true actually in some Alzheimer's trials as well.
Great, thanks. There's a question here that I think I'll take briefly and then come back to you. The question that I'm going to take is, I want to make sure I read it correctly here. Essentially, the question was, do race and ethnicity play a role in clinical trials? And the answer to that is yes. We know that the people who are participating in clinical trials today, unfortunately, are about 95% or more non-Hispanic whites. And that's true in all clinical trials, not just in dementia trials, but it is also true in dementia trials. And we know, of course, that that is not representative of our population. And so if we want to find medications that work for everyone in the population, we really need to be including everyone from the population in those trials. So I would say that the answer to that is yes. Now
I would just qualify it's partly we don't know because of the answer that you gave, right? So if you're only studying one group, it's harder to make conclusions that are generalizable. In all trials, we do try to understand after the primary analysis is done, we do look at all the different subgroups. But if there's not a big representation of a particular subgroup, it's harder to find results that are statistically different. They may be numerically different, but it's harder to demonstrate statistical difference. So we really do need to increase the representation in clinical trials.
Thank you, Jim. One more question back to you, and this is about the vaccine in particular. The question is, in regard to the vaccine, how would it be determined if a person needs one?
A vaccine for anything?
I'm assuming they're discussing the vaccine trial that you mentioned.
Right. So the vaccine trial is, first of all, not a trial yet. I mean, it's funded, and we're doing all the pre-work before we start the trial. So all clinical trials have what we call inclusion and exclusion criteria. This means that we have to decide what people we're going to study, right? And so what people would be included based on, do they have the disease? Are they the right age? And who will be excluded? Do they have some other factor that may confound our ability to understand the effects? And so each trial is different, and they have different inclusion exclusion criteria. And so when we are ready to register the trial in the clinicaltrials.gov, all of those inclusion exclusion criteria will be highlighted. In terms of vaccines in general, there are recommendations for approved vaccines as to who should get them and why. So these are everything from flu and pneumonia vaccines in older adults to measles vaccines in children. There are recommendations based on the preponderance of the evidence.
Terrific. Thank you very much. So, Dr. Galvin, I do have a few slides that I'm going to wrap up with, but I'm afraid we are out of time for the Q&A session today. I want to thank you very much for your time and your expertise today and for sharing your information with us, particularly also for taking the audience questions. But we're going to let you get back to your other work now, and I will wrap up. Thank you very much, Dr. Galvin.
Thank you, everybody.
Right, I just want to make sure I'm sharing my screen here. Fantastic. So really exciting updates, you guys. As Director of Scientific Initiatives here at LBDA, I am personally very encouraged at the progress that the field is seeing today. One of the things that struck me about today's presentation, I hope you heard this as well, was that of all of the experimental drugs that were discussed, they all worked in different ways, or they have what researchers would call different mechanisms of action. So we know that these are not the only mechanisms of action that researchers are studying. Scientists are also actively exploring medications that are related to other mechanisms of action, from preventing synuclein from forming Lewy bodies in the first place, through modifying levels of various neurotransmitters in the brain, to even blocking amyloid, amyloid beta. Now, that last part about blocking amyloid beta might come as a little bit of a surprise to you, but I can tell you that half or more of people with LBD have very high levels of amyloid beta in their brain in addition to Lewy bodies. And so there's a thought that treating that amyloid beta might also improve their condition. Most of what you heard about today was related to cognition and what researchers refer to as function. How is a person doing in everyday life? But of course, as Dr. Galvin mentioned, we know that cognition is only a part of the picture. Researchers are also planning trials to address many other aspects of the disease, such as motor symptoms, hallucinations, and delusions. When these studies are launched, we want you to be among the first to know. We want you to be among the first to hear when these new studies become available. There were several questions that came through today that we didn't get a chance to address, but they were, when might a phase 3 be launched from one of these studies? We don't know the answer to that yet. There are lots of factors that will come into play to that, but when we do know the answer to that, LBDA wants to bring that directly to you and make sure that you are aware that the trials are happening and when, and how you can find out more and potentially volunteer if it's right for you. So there are really two ways that you can learn about new trials through LBDA. The first and easiest is to sign up for the Lewy Trial Tracker. The Lewy Trial Tracker is simply a contacts registry for people who want to be informed about new clinical trials related to Lewy body dementia. To sign up, simply go to lbda.org, navigate to the Lewy Trial Tracker page, and complete a brief survey that tells us about you and your research interests. Rose is also going to drop a link to that into the chat now. We use the information that you tell us on that survey to inform you by email when a new study launches that fits with what you told us about yourself in the survey. This is a really convenient way to ensure that you are notified when new studies launch. Now, a couple of really important points about Lewy Trial Tracker. First of all, signing up for Lewy Trial Tracker is not a commitment to join any research studies. It's simply asking for more information so that you can then determine at a later time whether you would like to volunteer in that research study. So we also do not share your information ever with study teams. Rather, we use that information only to inform you when a new study launches. And then if you see information about a new study through Lewy Trial Tracker, it will be up to you to then reach out to that study team. Now, we do share the contact information and the sites at which the research is happening when we share that information with you, so you will know who to reach out to learn more about this study so you can determine whether or not it's right for you. The second way that you can learn about new research opportunities through LBDA is to occasionally check our clinical studies page on our website. And you can find that fairly easily, but we're going to drop a link to that into the chat as well. And what to know about our clinical study listings is that we aim to list every study that is LBD related, that is currently seeking volunteers, and that is open in at least 2 locations. We also list numerous online studies that can be completed from the comfort of your own home. And some of those will be things like simple surveys and questionnaires, but others will be more involved studies that may ask you for things like a genetic sample, but you can do that from your home through a cheek swab, essentially. So some of these studies will be relative that you can do virtually will be relatively simple, whereas others will be somewhat more involved. But we do want you to know that even if you live very far from a major medical center, there are still ways that you can directly get involved in LBD research and make a difference for the future. Well, I hope you've all found today's webinar informative, but unfortunately we are out of time. On behalf of LBDA, I would like to thank you all for taking time out of your day to join us today, and also thank Dr. Galvin once again for sharing his expertise with us. As a quick reminder, you will receive an email in about 1 week with the link for the recording of the presentation, as well as the resources and links that were mentioned in today's webinar. So if there's anything you didn't quite get a chance to write down, don't worry, you'll hear about it again in about a week. We invite you to visit our landing page on our website to stay informed about upcoming webinars and to access past recordings. Rose is going to drop that link into the chat now. Speaking of upcoming webinars, our next webinar will be 2 weeks from today on Thursday, April 3rd at 2 p.m. Eastern Time. Join us then and Dr. Jennifer Goldman for an informative and supportive webinar in honor of Parkinson's Disease Awareness Month. This webinar will aim to empower both individuals with Parkinson's disease dementia and dementia with Lewy bodies and their care partners with knowledge and tools to navigate this challenging journey. This session will delve into the critical transitions related to cognitive decline, provide valuable insights and practical advice on how to recognize the signs and symptoms of this cognitive progression to dementia. This will be an excellent webinar, an excellent presentation, and you can register now with the link that Rose is dropping into the chat. Finally, I do want to encourage you, when you leave today, a survey will launch. Please do complete that survey if you have time, because it does help us inform our content. We take those very seriously because we are here to serve you. And with that, we're going to drop off now, and we look forward to seeing you at the next community webinar in March. Thank you very much.